Please listen carefully.
Hello and welcome to GasGasGas. This is the best podcast for the FRCA primary exam. Our goal is to fill your brain with all this highly useful information. You might be in the gym right now, commuting, or ironing your scrubs. Regardless, the revision is eventually going to end, but for now, expect facts, concepts, model answers, and the odd tangent. Make sure to check out gasgasgas.uk. The show notes there's loads more detail. Make sure to like and subscribe. Anyway, buckle up, get ready for your mind to be bent into a new shape, and let's get on with the show. Hello everyone, this is James at GasGasGas. Welcome to our final, yes thank God, final opioid episode. And today we're just going to work through making some sensible comparisons between different opioids and when and where we might choose to use them. So that when we come up against this in the exam, we can sling off a sensible answer and continue progressing that station. So I hope you've all had a cup of tea, you're ready for action, and we're going to get straight into it. So as we all know, opioids are a significant cornerstone of anaesthetic practice. You know, they're making up that triad of anaesthesia with their analgesic properties. And we utilise these analgesic properties in a number of manners. Obviously, the barn door one is surgery hurts. So if someone's rummaging around inside your abdomen, then perhaps we need to give someone pain relief. But our activities also cause discomfort. For example, laryngoscopy. Now, in a general ASA1 human, the stimulating effects of laryngoscopy probably aren't the end of the world. However, if you've a patient who is teetering along that marginal line of physiological stability, causing them to have a stonking heart rate and blood pressure whilst you rummage around inside their larynx, might have implications. The immediate patients that come to my mind is the eclamptic parturient who needs an emergency general anaesthetic. You really don't want to drive their blood pressure unnecessarily high. You might end up in a territory where they have a stroke. Or for example, cardiac anaesthesia, bit of a wobbly patient, you push their blood pressure up and their heart now has to contend with a massive afterload. That's also bad news. I'm sure we could think of 1,000 other reasons why we should be thoughtful with our use of opioids. But as we've certainly covered through all these episodes, we know that all opiates are not made equally in this world, and there's no one catch-all perfect drug that will solve all your conflicting requirements for analgesia, sedation, etc., etc. Now, each opiate has a distinct gaggle of pharmacokinetic and pharmacodynamic properties that make it a better choice or a less better choice for an individual scenario. In a Viva, they want you to be able to justify your decision making as opposed to just saying alfentanil for RSI, because, you know, you're not a robot, you're a physician. So we're going to compare, in a few different situations, morphine, fentanyl, alfentanil, and remifentanil. And we're going to touch on their pKa, their protein binding, some comparative potencies, and then try and tease out when you might be leaning towards one more than another. How are we going to do it? Well, this time we're just going to try and structure it in questions. And for that to take place, the rumbling examiner omnipotent voice has to come back into play from the podcast episodes of yore. So, without too much further additional waffle, we'll get on with it. Hello, Doctor. Welcome to your pharmacology/clinical station, because we're fudging this Viva. You are anaesthetising a patient for a laparotomy for large bowel obstruction. They have not been vomiting. It's a suspected malignant obstruction. They are 75 years of age. Their comorbidities include high blood pressure and gout. Please compare and contrast remifentanil, alfentanil, or fentanyl as your induction opioid of choice. So this is a compare and contrast question. And it's important to realise it's very easy to become bogged down just listing off a ream of numbers and data, and that's really boring, and you might find yourself getting lost in the long grass when you just can't quite remember the pKa of fentanyl, for example. Now, it may be that the examiners really want to hear the pKa for fentanyl. The odds are they'll ask you that if it is really pertinent to the question. So anyway, how I would answer this question. So it sounds as if this gentleman has a bowel obstruction picture and no clear respiratory history or respiratory distress at this point in time. When conducting an RSI, it's important to consider the speed of onset of agents in order to facilitate a prompt intubation with the shortest period of time of a loss of airway reflexes being present, and to also weigh up familiarity with agents. So when considering fentanyl, alfentanil, and remifentanil, I know that the onset times of alfentanil and remifentanil are a fair bit faster than fentanyl. Fentanyl taking 3 to 5 minutes, whereas alfentanil and remifentanil about 90 seconds to reach peak effect from an IV dose. Onset time is important, however also offset time is an important consideration if there's a potential for encountering a difficult airway or an anticipated difficult airway. Alfentanil is very effective but does not last very long. If there's going to be a prolonged period of airway instrumentation, it may be a better choice to choose remifentanil via a target-controlled infusion. This would mean that you get a consistent level of analgesia on board alongside its favourable onset time. A counter-argument to this is potentially the use of fentanyl, bearing in mind its onset time. An argument can be made either way here, as it takes 3 to 5 minutes to reach peak effect, and there may be a period of time where the patient has a slightly depressed state of breathing that is longer than for perhaps with using remifentanil or alfentanil. However, fentanyl has a prolonged period of effect which might facilitate a greater period of time in order to achieve a safe intubation. Comparative dosing here between these agents, I would elect a dose of fentanyl between 1 to 3 micrograms per kilo. Alfentanil, in this situation, about 10 to 15 micrograms per kilo, noting that the dose is an order of magnitude greater, approximately, than fentanyl. This reflects the potency of fentanyl being greater than that of alfentanil. And with remifentanil, I would be unfamiliar with using this in a bolus dose. I know it's up to 3 to 4 micrograms per kilo. However, I would use a remifentanil TCI model such as Minto, aiming for an effect site concentration of 4 to 5 nanograms per mil to facilitate intubation. So moving this hypothetical clinical scenario on, you've decided to conduct an infusion of opioids. Tell me, how do the offsets differ between remifentanil, alfentanil, and fentanyl? Yes. So the important pharmacological concept to consider here is the context-sensitive half-time of these different agents. Context-sensitive half-time being a concept whereby the period a drug is infused over has a relationship to the clearance of that drug, or the half-time of that drug. The longer the infusion, the longer the time it takes for drugs to clear. Drugs that are typically very lipophilic tend to have a longer context-sensitive half-time, as they are more likely to accumulate in adipose reservoirs within the body. Now, these three agents are actually almost polar in some regards. So fentanyl has a very long context-sensitive half-time, whereas remifentanil and alfentanil have shorter context-sensitive half-times, and remifentanil in particular is entirely context-insensitive. What I mean by that is that for any period remifentanil is infused for, when that period of infusion is stopped, the half-life will not alter, the half-life being around 9 minutes for remifentanil. They might ask you at this point in time, folks, to draw that graph of comparative context-sensitive half-times for drugs. I'll put it in the show notes. Not to forget that alfentanil has a short context-sensitive half-time compared to fentanyl. That's why it's often a typical opioid of use in the intensive care environment. Fentanyl could be used in this patient population. However, given a patient might be intubated and ventilated for a number of days, you would end up complicating and muddying the picture on sedation hold for these patients. So, Doctor, you've
find yourself on a colorectal list, and you note that there's a short case, an inguinal hernia, and then a long case for the rest of the day, a colorectal cancer patient who's having a laparoscopically assisted AP resection. Talk me through the various approaches to pain relief intraoperatively and postoperatively in this patient cohort.
Yes, right, okay. Well, laparoscopic-assisted colorectal cancer surgery is painful during and after the operation, but is generally confined to quite a small area of the body, i.e. the lower half of the abdomen. So there are a number of overarching techniques that could be utilised in this situation. So intravenous versus regional analgesia. And I'll break regional analgesia down into either a intrathecal or epidural approach, and then intravenous anesthesia down into bolus or continuous infusion. Thinking about regional approaches first. An epidural will certainly yield excellent pain relief if well sited in this patient. However, it may be excessive and the balance of risk versus benefit shift away from an epidural approach. The chief cofactors I'd want to understand before making that decision is the patient's respiratory baseline. Do they have COPD? And whether or not the surgeon expects for it to be a laparoscopic case or if it needs to be converted into a laparotomy, in which case an epidural might make more sense. Intrathecal approaches. So if I were to site a spinal in this patient before general anaesthesia, that would likely cover the main pain stimulus of the first half of the operation. These cases can take quite some time. However, that bupivacaine would unlikely be of benefit to the patient post-operatively. A good choice here might be a spinal containing preservative-free morphine, as this would provide analgesia for perhaps the first 24 hours following that intrathecal injection, whilst avoiding some of the systemic side effects of opiate administration. Now, this isn't titratable, and it may be insufficient to cover the marked pain stimulus of the surgery itself. Intravenous approaches. So I could bolus the patient IV opioids, such as morphine or fentanyl, and titrate these to pain stimulus intraoperatively. This may require quite high doses intraoperatively of these agents, and that might slow the wake up afterwards or leave the patient unexpectedly sedated and groggy. The opposing option for this is a remifentanil target controlled infusion during the operation. This allows titratable pain relief, which can be easily modified to match the surgical stimulus at hand. The counter to this is that it won't provide any lasting pain relief post-operatively. How might post-operative pain be managed? A patient-controlled analgesia delivered through a dedicated pump system syringe into a cannula of either morphine or immediate release oxycodone would be an option to give the patient control over their pain relief post-operatively. However, when comparing this to intrathecal morphine, would carry a higher risk of having systemic side effects that might limit the dose that could be given and the pain relief that could be achieved.
So what are you going to do?
For this intervention, as long as the patient has a disease-free respiratory system and the surgeon is thinking it likely that it is going to be a laparoscopic procedure, unlikely to convert to a significant open incision, I would first deliver intrathecal morphine to this patient before conducting a general anaesthetic. I would use remifentanil TCI intraoperatively and likely give the patient some additional opiate pain relief on extubation and review them from the perspective of how effective their intrathecal morphine is in controlling their pain before they leave recovery.
What about the side effect profile of intrathecal morphine?
I would describe the side effect profile of intrathecal morphine as having one chief concern, and that is delayed respiratory depression as that morphine shifts throughout the spinal cord and can affect the respiratory centre. Now, this is dose dependent. I would likely use a 100 microgram dose. It is important that the patient goes to a ward that is familiar in managing post-op patients who've had intrathecal morphine and naturally are trained in administering naloxone. I would have naloxone preemptively prescribed in case there is respiratory depression.
Why not just use fentanyl?
Fentanyl, whilst an effective intrathecal opioid for short procedures, will unlikely provide any clinical benefit in pain relief for this patient post-operatively. It does have a much reduced potential for respiratory depression in the doses used. This is purely because the agent is very lipophilic and it is less likely to shift up the spinal cord. It's more likely to be cleared by the plasma.
Are there any other risks with intrathecal opioid dosing?
The chief risk that comes to my mind is ensuring dose accuracy. Whilst it might be quite commonplace to administer 10 milligrams or more to a patient intraoperatively of morphine, a 10 milligram dose intrathecally would certainly cause a number of problems, the chief being respiratory depression. I mentioned earlier the dose intrathecally is 100 micrograms. This is 2 orders of magnitude less. The other important component to consider here is that the agent you are administering is preservative-free to avoid any arachnoiditis type problems.
Well, excellent. Moving on, more pharmacology questions. Tell me, what are the differences between the metabolism of morphine and fentanyl? And which would you pick in a patient with significant renal failure?
So both morphine and fentanyl are metabolized by the liver before these metabolites are cleared renally. So morphine is glucuronidated in the liver to morphine 3-glucuronide and morphine 6-glucuronide. Both are active metabolites. The chief issue is that these active metabolites are renally excreted and accumulate in renal failure. This can lead to an increased odd of morphine toxicity, chiefly sedation, drowsiness, and respiratory depression, increasing the odds of respiratory failure in this patient, as well as post-operative pulmonary complications. Comparing morphine to fentanyl, fentanyl again undergoes liver metabolism. However, it is N-dealkylated into norfentanyl, and it's subsequently hydroxylated. Norfentanyl is not an active metabolite. If I were to choose between the two, I would elect to pick fentanyl as a post-operative opioid analgesic.
Now, if I give you the room and say, what post-operative analgesic would you elect for a patient with marked renal insufficiency?
I would take a multimodal approach, ensuring that I've used simple analgesics, such as paracetamol, before considering stronger opioids. Codeine could be a choice, however, it is ultimately metabolized into morphine 3 and morphine 6-glucuronide, which could accumulate in renal failure. Tramadol also has prolonged clearance in renal failure. I would likely avoid that too. Whilst fentanyl, as we mentioned earlier, is a safe choice, administration on the wards of fentanyl is challenging. It has a very low oral bioavailability, and therefore its absorption profile can be quite different if the patient has a fentanyl lozenge versus swallowing liquid fentanyl. I would elect to choose oxycodone instead for this patient, immediate release, as modified release would not be licensed. Oxycodone can still accumulate in renal failure, and I would use a reduced dose and an extended time frame between those doses. If the patient had devastatingly poor renal function, then I may elect to use buprenorphine. This is completely hepatically cleared. This is available in patch form, and there are intravenous preparations, as well as oral preparations. It would be pertinent in the patient with renal failure to ensure sensible regional or local anaesthetic-based analgesia is considered and provided. Oh gosh, that felt like a lot of talking actually, but hopefully we can now compare and contrast and balance up some of the nuance when they're going to be asking us about opioids. So we're just going to do a quick smash and grab about morphine, fentanyl, alfentanyl, just so we're all on the same page. So morphine is still a reference opioid, which everything else is measured against. That's why we have conversion tables that convert to oral equivalents of morphine. Morphine has a pKa of 8, which means actually its unionized fraction is pretty small. It's 23% unionized. It's also got quite a low protein binding, and it's pretty low in the lipid solubility statistics. If we were to brand it as having a lipid solubility of 1, fentanyl would have a lipid solubility of 580. So, morphine, if you pour morphine on butter, going to take a while to get in there. Whereas if you pour fentanyl on butter, it's going to get in there. Wait, yes. I'm sure that'll be actually quite an interesting experiment. Now, why do we use morphine? Well, actually, it lasts a really long time because it has low lipid solubility. It takes a while to soak in. It takes a while to get to that CNS space, looking for those opioid receptors, lurking about throughout your CNS, which means it hangs around for quite some time because it can't get out very easily. Gets in slowly, gets out slowly. That's why it's also useful from an intrathecal perspective, because it soaks in slowly and fails to come out quickly. So we'll counter that, we're thinking fentanyl. And now we're all thinking, well, why on earth do we even use fentanyl? Morphine's great, isn't it? Well, morphine is pretty good, but it binds to most of those mu opiate receptors, and its side effect profile is perhaps a little bit more negative compared to fentanyl. A number of individuals are tempted to just use sufficient fentanyl to achieve adequate pain relief, knowing it's more mu opioid receptor specific, and therefore get a bit less of that woozy, dozy feeling, that dysphoria that sometimes comes along with morphine, and it's less nauseating. I often reach for fentanyl for short procedures, the quick and painful bum abscess that needs to get done, encourage people to give 100 mics and then another 100 mics of fentanyl and get them pretty comfy on that. I also reach for it in A&E when transferring a patient either to CT or getting them ready to take them to a different hospital. Why do I do this? Well, you could use alfentanil and set up an infusion. That's one more line, one more pump, and one more thing to go wrong. Whereas you could just get the 500 mic ampule of fentanyl and fill that patient with fentanyl. And actually, you don't have to worry so much. You've got a good amount of opioid on board and you can just manage that propofol infusion only. The odds are they are not waking them up today if they're going for emergent neurosurgery. Whereas alfentanil is short and sharp. You give it, boom, pain relief, and then it's gone. Takes 90 seconds to work, 5 minutes to wear off. When should you be using it? So in RSIs that clearly need potent inhibition of the hypertensive response to laryngoscopy. If you're doing a GA in a clamptic patient, use a big dose, like 2 milligrams. Again, like fentanyl, it's really cardiostable. It's important to think about the pKa's of alfentanil, and comparing it to fentanyl is quite interesting. So alfentanil has a pKa of 6.5, which is well below your physiological pH, your 7.35, 7.45 world. This means it is 89% unionized. That means there is a bucket load of alfentanil piling across those membranes, getting to those receptors and having an agonizing party. And we like agonizing parties, even though they sound awful. Whereas if we contrast it to fentanyl, well, fentanyl's quite different. Fentanyl has a pKa of 8.4. So actually, it is 9% unionized at its pH. You're thinking, well, hell, why is the onset time of fentanyl faster than morphine being like 20 minutes, when it's so unionized? Well, it's because of its lipid solubility, and it just gets where it needs to go because it soaks across those fatty layers. If you were to compare lipid solubility between fentanyl and alfentanil, you will find that fentanyl compared to morphine is 580 times more lipid soluble, whereas alfentanil is only 90 times more lipid soluble. So whilst pKa is an important contributor to onset time, it is not the be-all and the end-all. So there's a bunch more example questions in the show notes if anyone wants to have a bit more of a read. I'm excited to have finally closed out opioids. And you might be wondering, but James, you've forgotten codeine. I meant to forget codeine. We're never going there. Unless, of course, you all send me an email begging me for an episode on codeine, in which case I will get my 2d6 hat back on and proclaim you all non-metabolizers. It's worth memorizing the pKa's, the protein bindings, and the relative lipid solubilities so that you can smoothly chat opioids in the exam and handle any SPAs that might try and compare and contrast these agents. Don't forget about opioid-induced hyperalgesia. All of the opiates can do it, although remifentanil is perhaps the best offender because we can give so much of it with few side effects because of its offset profile. Also, do not forget chest wall rigidity, which again can cause you bother, but you can paralyze your way out of if you've caused it during induction. If a patient just has it somewhere else, well then you are in a spot of bother. For example, you're doing an awake fibre optic with loads of Remi, and then the patient gets all stiff, then you are in a pickle. Oh, and also, don't forget that remifentanil can be used in a PCA, and it is purported to be quite nice if you happen to be a labouring lady. Anyway, that's me. Thanks for listening to Gas Gas Gas. We have smashed over 10,000 listens now, which is cracking. Over 400 subscribers. So like it, tell your mates, and I'll see you for the next time, which is going to be local anaesthetics. I'm ready for a change in direction. We've done too many opiates. Anyone would think we have a problem. Thanks for listening, guys. I hope you found it useful, but if you found it awful, do let me know. Please like and subscribe, register with whichever podcast platform you find yourself using, and leave a comment if you think I need to square something away. I just want to make sure that you guys know that every day you are getting better at this. There is a bucket of content to try and consume, and it is like drinking from a fire hose. Take it day by day, don't overcook yourself, don't freak out, and keep studying.